what does that term evoke in you?
I think of like your ear and hearing too.
Okay, so obviously, yes, we're going to be doing something with their hearing, but it's not cosmetic surgery on the ears. What's the rehabilitation part?
Is it kind of like the correction and learning how to use what's in here?
That's a good answer. What were you going to say? Okay, good. You both have used some terminology that's critical. First of all, what's the difference? Let me back up a little bit. What's the difference between oral rehabilitation and oral habilitation? As opposed to habilitation is what we do with people who are prelingually hearing impaired, meaning that they have an impairment of their hearing before they've mastered language. So basically what we do with children. Whereas rehabilitation is what we do with individuals who already have mastered language. So typically with older kids and adults. Okay? So you mentioned a word that I like, compensation. How do we compensate for hearing loss? Yes? Amplification. And I'm glad that you said amplification and not hearing aids, because hearing aids are just one little piece of the amplification pie. You have an advantage because you work in that front office. What are other things besides hearing aids that people might need that you've seen? FM systems, yes. They might have a streaming device that connects their hearing aid to technology, like their television, their computer, their MP3 players. So amplification are any of the devices, or what's the plural of apparatus? Is it apparati? I don't know. But the devices, the things that they're going to use to help compensate for or to improve their access to the sound signal. We might have, in addition to compensation, we might be involved in remediation. What's the remediation that would be involved? What do we mean by remediate? Compensate is when you try and get around an obstacle, but remediation is what?
Actually fixing the problem.
Trying to fix the problem. And what kind of problems do we maybe need to fix for people who have hearing loss?
Communication difficulty.
Communication breakdowns, yes, that's absolutely it. So what kind of communication breakdowns might a person with hearing loss have?
Maybe they might not speak loudly enough to use
They have a problem monitoring their own, yeah, so they may speak too soft or too loud, yeah, so self-monitoring. Great. What else? Yes?
Maybe hearing with background noise around you.
Okay, so, right, we call that auditory figure ground, where they're unable to adequately identify or hone in on the speech signal and background noise. Guess what? That's a skill that can be learned, and there's actually some really cool computer-based software that's designed to do that now. We don't have to sit there with our radio tuned to white noise in between frequencies, or and start gradually adjusting it. We actually have computer-based programs that are designed to do that for us, and do it much better, I might add. And we have evidence to back it up that it works. So yes, that auditory figure ground, a very important skill. What else? Who here has ever tried to communicate with maybe a parent, a grandparent, someone who obviously has hearing loss? What was that like? What happened?
My grandma has a hearing loss, so a lot of the times she just fills in her own part of the conversation.
Okay.
And so we'll say one thing to her, and then she'll be like, "Oh no, it's a blanket in the dryer," and we're like, "We're asking what you want for dinner," and so it's like completely different thing.
Yeah, we have to work on sound discrimination and auditory comprehension. Absolutely. My point is that there are some things that we can try and compensate for. We can try and overcome or compensate for the hearing loss by providing them the best possible access to auditory signal. And that's typically done through amplification. But there are also some skills that can be taught, that can be improved. And it's typically related to their listening skills and to their oral communication. Not always is the problem that we need to try and fix the patient. Sometimes we need to fix their communication partner. A hallmark complaint is Mr. Jones comes in, his wife is in tow, she made him come because he can't hear. He's pitching a fit because he can hear just fine, she just mumbles, and so does everyone else. And usually he has some hearing loss, and usually she's not mumbling. But you know what? Sometimes she is. And so we may need to actually engage in some clear speech training or some communication enhancement training with significant others as well. So that's something to consider. But the point in all of this is that oral rehab is evolving as technology evolves, as remediation strategies evolve, and even in its name, because we're starting to see a movement from the use of oral rehabilitation to auditory rehabilitation, because it goes beyond oral ear to the entire auditory system. And the auditory system begins with the ear, but it certainly doesn't end with the ear. It involves the brainstem, the neurological pathways between the ear and the auditory comprehension centers of the brain. So you may start seeing this shift from the use of oral rehabilitation to auditory rehabilitation. I don't really give a rip which one you use. When I was in school, we called it hearing impaired therapy. So the fact that I even caught up with them using oral rehab is probably as much as you can hope. Eventually, auditory rehab will probably roll off my tongue. Right now, it doesn't. So you can use either one. Be aware that our goal is to improve access to auditory information as well as to remediate the communication interactions. Okay? So that's what we're hoping to facilitate. That said, obviously, it's an interactive process. And it's going to involve you as the clinician, and at a minimum, the patient, and more often than not, the patient and other significant individuals in their circle of friends and family. Okay? But it's more than just hearing needs and speech. Let's talk a little bit about hearing loss. I think it's important to understand why is this even an issue? Why do we even talk about it? Well, the current statistics tell us that roughly 17% of the US population has some degree of hearing loss. Okay? So over 36 million people. If we're dealing with the folks that are slightly older than me, that 50 and over population, the percentage goes up to 30%. In your age group, imagine, you ladies are not over 25 yet. So, well, anyway, close. 12 to 24, so the young person. Isn't that sickeningly sad that if you're 25, you're no longer considered young? So think about how I feel having just turned 48 a couple weeks ago. I guess I knew this, but it was really, it hit me like a load of bricks this past semester when it dawned on me that probably 95% of the students that I'm teaching are old enough to be their dad. And especially when the student said, well, yeah, you're 3 years older than my mom. Because I don't think of myself as old, particularly because I have a child who just turned 11 today. But that's because we took a little bit longer for that whole family thing to happen for us. So I was 37 when he was born. But anyway, your generation is growing up in probably the noisiest period that has ever faced our planet. And as a result, your generation is showing the highest increase in the incidence of hearing loss any generation before. Your age cohort is, as a group, showing, if we were to take everyone's hearing test results in this room and average them out and plot them out on an audiogram, would look very, very similar to if we took those same results for everyone in my generation. Isn't that nice to know that in your 20s you're showing hearing levels very similar to a typical 4-year-old? And it's because of the inundation of noise. You may have heard this before. It bears repeating, because you probably couldn't hear it or didn't hear it the first time. My little soapbox. And Addie, I'm not picking on you, but I just know you well enough that you're not going to frequently do this. If someone is standing at an arm's length from you, and they can hear, now I'm not saying sing along with it, but they can detect the sound of your iPod or your other MP3 player, guess what? You're damaging your hearing permanently. Turn it down. The rule of thumb is, if you have the Apple iPod trademark brand of MP3 player, try to never exceed 50% full volume. Absolutely never exceed 2/3 full volume, or you are damaging your hearing. And the more above it that gets, the shorter the period of time before that damage is permanent and not temporary. If you are consistently using your iPod or MP3 player in situations where you are needing that increased loudness because of the conditions, then you need to invest in either custom earbuds that will block out some of that annoying background noise so you can lower it, or you need to get noise canceling earphones. Stepping off my But the reason that your generation has an incidence of hearing loss that is approaching that of the over 50 population, that's scary when you think of that. The 12 to 24-year-olds, there are almost as many of them with hearing loss as there are people over 50. And guess what? Proportionately, there's a hell of a lot more people who are over at the age of 50 than there are in the 12 to 20, 24-year-old. Think about all your parents and grandparents and potentially great-grandparents. All those people are over 50. And we're talking about one 12-year range of the population. Scary. Okay. So prevalence gives us a snapshot of segments of the population, kind of a static look. That's prevalence. So the prevalence, how is hearing loss impacting population? But we can also talk about the incidence. And incidence deals with a point in time. So a specific point in time. And that's really difficult for us to determine because we don't usually track data about hearing loss in that fashion. That's why when I write a report, like I evaluated a 1-month-old today who referred on her newborn hearing screen. So she needed to come in because she's not deaf. That's according to her newborn screening, she wasn't hearing. And so I will typically, particularly with my kiddos, I will write things like tympanometry revealed type A consistent with normal middle ear function at this time. Patient had robust otoacoustic emissions suggestive of normal hair cell function at this time because it might change. It could change. And I want to make sure that my butt is covered. Have you ever heard the term CYA, cover your ass? You need to. Am I right, ladies? Do your supervisors tell you that? Yes. Things can change. I had, my son was running a fever. And Will's never sick, but he, once in a while, he gets these oddball fevers that spike to like 100, 300, 400. Now he's still running around, he's eating like a horse, playing, doing everything, but he's got this funky fever. And I also know he has a very high pain tolerance. So it finally dawned on me, maybe it's kind of ear infection. So I'm looking in his ear with my otoscope, and it looks like a pearl. It's beautiful, it's got retracted. If it weren't for his brain, I could see right through to the other side. I'm like, okay, well, no. So I take him, call up the doctor's office. They can't see him until tomorrow, so I take him in. And doctor looks in his, and I looked in his throat too. I can see his tonsils. They were like red and inflamed. And the doctor looks in his throat and goes, oh my gosh. And I was like, what? So there's these huge pus pockets on his tonsils. And I had just checked his ears at like 7 the night before, and this is like 8:30 the next morning. So then he looks in his ears, and he's like, oh my gosh. I look in there, and it looked like someone's eyeball the morning after the night before. It was so bloodshot. So, and I mean, we're talking less than 12 hours later. So things can dramatically change. So it's very difficult for us to identify incidence numbers that tell us at any given point in time. But we do know the incidence in newborns. So at that time frame, we're dealing with that specific time frame. And depending on whether or not you're talking about any degree of hearing loss, or whether you're talking about severe to profound hearing loss, the incidence rate runs from anywhere from 1 in 10 to 12,000 births. There is some degree of hearing loss. If you include every degree, it's again unilateral versus bilateral, then it's about 1 in 10,000. You only talk about severe, profound, it's more than 12,000. hearing loss is the number one early diagnosable congenital condition. Hearing loss occurs more often than cleft palate, than diabetes, than PKU, than a lot of these other conditions. So why did we wait until the dawn of the 21st century, in the 2000s, for it to be mandated that we screen every newborn infant for hearing loss? When it's the most common, it's highly treatable, and the outcomes are better the earlier we identify it. And we waited until this past decade to mandate screening for it, and yet there are a gazillion conditions that they take blood from the infant at birth and run tests for, many of which we can't treat. Sure, knowing they have it is great, so we can break the news calm down. Oh, by the way, Johnny's not going to survive beyond his 3-month or 6-month checkup or 3-year-old checkup because he has this horrible condition, but we can't treat it. Why have we been testing for those kind of things since God made dirt, and yet we waited until just in the last 10 years to mandate screening for it? It just, to me, it doesn't make sense. But anyway, anytime we rely on U.S. Congress or government to implement rules and logic. Yes?
What's the procedure for testing? Like not the full up procedure, but what do they do for newborns test? Because they can't do the
Right, sure. Yeah. Good question. And we'll talk about it in greater detail, but I'll address it now. But we typically have 2 basic screening tests that are done in the hospital. They either do otoacoustic emissions, where they have a device that looks very much, if you've ever had a tympanogram done, middle ear test, blood pressure test, a tip that looks very much like that goes in the ear. They press a button and it puts some sound down in the ear. And if everything's working the way that it should, and the cochlea is stimulating, the hair cells in the cochlea are stimulating the hearing nerve, when that hearing nerve fires, it's a little electrical signal to go to the brain, a little echo emerges. Just like if you have a piano keyboard, when you hit the key, the little hammer actually hits the string, you hear a sound. Well, that's basically what happens, is those little hair cells in the cochlea are like the hammer on a piano that ding, the hearing nerve, which is like the strings, that allows you to hear. And there is, in this little probe, not only a tone generator, but a little microphone that listens for those echoes. They're called otoacoustic emissions. And if we get robust emissions, echoes back, and we know what the normal levels are, then we know, at least to the level of the cochlea, hearing's normal. So we know there's no conductive loss, we know there's no sensory loss, and we can be pretty doggone sure that there's no neural loss. So that's one way. The other way is that we can do an ABR, an auditory brainstem response, where we put sound cups on, we put electrodes on them, we deliver sounds, and we can measure brainstem brainwave activity, and there's a particular waveform that we're looking for, and then we can gradually reduce the loudness level until we see that waveform disappear, then we raise it back up until we see it again, and that tells us where approximately the threshold. For ABR, ABR has been going on for a long time. I mean, we were doing ABRs back in when I was in graduate school. Before any of you were born, okay, it was that long ago. So definitely from the clinically, I mean, it's been around for a long time, to have like true clinical applications has been since like the late 70s to early 80s. Otoacoustic emissions, again, have been around for a long time, but to have clinical utility probably since the 90s.
Can either of those methods be used for people who you think are falsely,
Yes, that's absolutely wonderful for identifying malingerers, people with functional hearing loss. But they can also be used to test other difficult to test populations. Folks who have cognitive deficits, folks who maybe are comatose. We can actually elicit ADR, waveforms, and otoacoustic emissions from people who are in coma. Now we don't know at the cortical level what's going on, although we can also, one of the tests that they often do now to determine if someone's brain dead is they will do cortical or middle latency or late auditory response testing to see if there's cortical activity in response to sound. So yeah, it's gotten very sophisticated. I love the whole, and I love the electrophysiology part because one of my true passions is auditory processing disorder, and that's one of the ways that we kind of work that out. Is if all the pathways and all of these electrophysiologic tests are coming back normal, but the person's still exhibiting problems following directions with discrimination, then we know it's probably not an auditory processing problem. It's probably a language comprehension issue. Because you will hear, there are people, psychologists, we had one in our department who swore there was no such thing as an auditory processing disorder. And when she saw the wonderful article that appeared in more than one ASHA journal talking about the speech pathologist's role in managing auditory processing disorder, she came to me and she goes, okay, I'm sorry. You were right. I was wrong. Because not often as a guy that you have a female say to you, I was wrong. Especially if you've been married for 18 years. You just get used to being the one that's wrong. Anyway, so very good question. Thank you for asking. And we'll talk more about it. But that's just, like I said, this is in my heart. I'm a pediatric audiologist and I'm an adult speech pathologist. Do I deal with womb to tomb in both professions? Absolutely I do. But if I was doing where my heart really lies, but you like that womb to tomb? Well, we do. I mean, I test newborn babies. I tested a newborn baby today and I had an 87-year-old at the other end. So I truly do. Anyway, I really love the fact that we are advancing technologically. And that answers the question that some people have, why do audiologists have to have a doctorate and speech pathologists only need a master's? Well, I think speech pathologists should need a doctorate too. You can shoot me now, but I do think that you should. But audiology, more so than speech pathology, is so technology-driven, and the advances in our ability to identify and remediate some of the disorders of balance and hearing have become so broad. Have you ever watched a TV show where they show like traumatic brain surgery going on? The person's still awake on the table, and they've got someone sitting in a bank of screens, and they're monitoring their neurological activity. So when the physician pokes here, suddenly their speech slurs, or the physician pokes there, and suddenly they can't remember something. You know who it is that's watching those monitors? An audiologist. Audiologists and neurologists are the only ones that are, by scope of practice, legal scope of practice, allowed to monitor neurological function in an operative condition. So there are audiologists who all they do is what's called interoperative monitoring. You do not want me to be that person because I did that during a clinical rotation in 1980, and haven't done it since. It was fascinating. I thought it was pretty cool, but just that saw going through the skull and the smell of burning bone as that saw was going through was almost enough to put me over the edge. Once we got through that, if they could bring me in after they've already sawed that hole in the skull, when then they go rooting around in there, then I'm fine. Because it can. There are, I mean, obviously there's blood vessels in the brain, but there are no pain receptors. So you could go rooting around in there. Huh? It's not all that different than like burning wood. That there's, if you've ever smelled burning flesh, like an animal, there's definitely a fleshy undertone to it. It's not easy to me. But anyway, we digress. So just know that we can identify hearing loss very early on. When it comes to the scope of practice for oral rehab, both speech pathologists and audiologists share some roles and others are very distinct. So when it comes to oral rehab, together we both have a role to play in counseling the patient and their families and caregivers. We can both engage in speech reading training, and we can both engage in activities around communication enhancement. That's something that you can do whether you're an SLP or an audiologist, or if you're like me and you're both, then it really doesn't matter. But in terms of what the audiologist's role is, we evaluate the hearing, we prescribe and dispense the hearing aids. If the person needs cochlear implants, we do the mapping, where we actually set the electrodes so we're not joining them out of their skull when certain sounds are heard. And we can take a look at and diagnose and manage balance issues, which frequently co-occur with hearing problems. There are a lot of conditions that cause hearing loss that also affect the balance system. Why? Because a significant portion of balance control is also in hearing. Speech pathologists, their role is more in the assessment of speech, language, and voice. Obviously, a person may have some swallowing problems if they have issues because they've had a stroke, which can cause hearing loss, believe it or not. If they've had a brain injury, things like that, and obviously can be involved in the assistive technology portion. But whereas we have some things that are very distinct, we also have these things that we share jointly. Okay. ASHA has some very specific I don't want to say recommendations because they're practice guides. Position statement, that was the word I was looking for. ASHA has come up with a position statement that includes some competencies that are required for someone who's going to be engaging in oral rehab. And they define oral rehab as services and procedures for facilitating adequate receptive and expressive language or communication in people with a hearing impairment. We kind of talked about that a little bit. So yes, the goal is to maximize communication for those with hearing impairment. And they have, and I've included in your slides, if you click on this link, it will actually take you to the position statement and the list of competencies that ASHA says that we have. And I would strongly suggest that you go to that, because so yes, that's a hint and a half for those of you who have never had me before. When I say stuff like that, I really do mean it. We're really going to take a look at that, because I will probably ask you questions about those competencies. Okay? When we are dealing with, and this kind of deals with your question to some degree, Taylor, we have different types of tests that can be used to identify hearing loss. We have objective or non-behavioral tests. We've talked about a couple of them already. ABR, OADs, tympanometry, acoustic reflexes. So these are the tests that we can do that don't require active participation on the part of our patient. So if we have that patient who's maybe not responding honestly about when and where they're hearing sounds, we're going to be able to figure it out. I used to, when I did a rotation when I was in graduate school at the VA, and they had kind of a, first time I ever heard it, saw it and shocked me, test to identify people who know her. And that is where, you know, they claim that their hearing is at this level, so then you go in at a level significantly lower than that, and you start using vulgar language, and you can see their reactions, and you know they heard you. So that's you know that was the old-fashioned way before we had some of these more sophisticated measures. So non-behavioral is where we're measuring the auditory physiology. We're measuring what's going on in the system without any active participation from them. Then we have behavioral tests, which are things like traditional audiometry. When you hear the sound, raise your hand. When you hear the sound, press the button. Where it actually relies on them actively participating. When we talk about assessment, we'll often hear audiologists talk about cross-checking or a battery approach. And that is when you use a combination of objective and behavioral measures to kind of look at the overall picture and determine what's going on. When I'm testing a baby, I will typically have to rely primarily on objective tests, because particularly with a newborn, they don't have very many behaviors that are very reliable that we can gauge. I mean, other than maybe we can do the startle test to present a really loud, annoying sound and see if they startle. But that doesn't really yield a whole lot of useful information about their hearing acuity, whereas if we're eliciting acoustic reflexes at a range that we know normal hearing individuals tend to respond within, that's one looks normal. If we have normal tympanograms, we can rule out that there's any problem with the middle ear. Then we do otoacoustic emissions, and we get responses down to about 30 or 35 decibels, which is about the minimum loudness that we can present and still be able to measure a response back. Okay, that looks normal. I can feel pretty comfortable, and I don't feel compelled to put mom and dad in the booth with that baby and present a loud sound, which is probably going to shock the crap out of the parent that's holding the baby too. So I don't know if that thing that I just saw was the kid responding to the sound or the kid responding to mom's jumping when I made her wet her pants because I just presented a sudden loud sound. Does that make sense? So I don't feel, because subjective testing is, by its very nature, potentially less accurate. So if I have 3 objective tests that I've just done that tell me this baby's probably hearing okay, I don't feel compelled to do a subjective test. Whereas when a kid gets a little bit older, and I can add that in because I know the level at which a normal 6-month-old will localize to sound, then yeah, I'm going to start adding that in because that's further confirmation. You were going to ask me. I could, but a lot of times, have you ever tried to take a newborn baby away from the parent? You need to watch Animal Planet sometime to see what happens when they try to take babies away from the mamas. It ain't pretty. Yes, we could. But to me, doing an additional test that's not going to change my diagnosis or my interpretation, to me that's almost unethical. I'm just basically padding my bill. Now, if healthcare law comes in and our fees are cut to the extent that they've initially been and they don't change it, then yeah, I'll probably do that extra test because I need to cover my time. That's horrible to say, but that's the reality. We've seen about a 36% cut in our fees since the new healthcare law took effect. And that's just phase 1. That's not 2014 when the real cuts are going to come in. So, terrible to say that, but that's the reality. I can't spend an hour with the family and do my testing and explain and interpret it and get paid $21.16 for my time. So my equipment costs more than that. So, but that's the reality that we're facing. So, not to chase you away from a career in audiology, because guess what? Fees reimbursement for speech pathologists are not significant too. We just need to be very afraid, because no one knows for sure how it's going to happen. But anyway, so we do typically use this battery approach where we cross-check and we do both objective or non-behavioral as well as behavioral or subjective tests. We can do screenings, which is what we do with newborns, but we can do that with school-age kids, we can do it with older people. And basically, we have a preset criteria that we say, if the person's able to hear at this level, they pass, their hearing is adequate. If they can't, then they fail. Okay? Usually, for traditional screening, like remember when you were a kid and you were in school, you put the headphones on, you just now raise your hand when you hear the sound. Typically, the criteria that is used, at least what ASHA suggests, is 25 decibels, but ASHA also assumes that they're not doing that in the cafeteria, or in the room next to the gymnasium where there's a game of dodgeball going on right now, which is what does happen. But anyway, so there's just a preset pass-fail criteria we're looking at. The gold standard is when we do the comprehensive assessment that includes the audiogram, so comprehensive hearing test, the bare bone speech, as well as including necessary objective measures as well. Okay? That's pretty much how we do it. Our battery is going to be different depending on the age.